Thank you very much. It's a pleasure to be here today. For a Brazilian, I think you can appreciate it's nice to be in Portugal, not only a beautiful country, but we speak Portuguese here. Actually, I was always jealous from my colleagues who were native English speakers because they have much less problems to give a lecture in English like I have. So then some years ago, I was invited to give a lecture in Portugal, and I thought that my time had come and I would really rock. But actually, after the lecture, I realized that the take-home message for everybody was that the Portuguese in Brazil was so different than in Portugal that I amuse everybody here. So now I reserve English for scientific lectures and Portuguese for politics and soccer. And today, oh, I think this is the wrong presentation. So I will ask, probably is the technical people here. So this is my lecture at 6 o'clock, so it's a good advertisement. Come at 6 o'clock. It will be a very nice lecture and debate about corticotemporal dementia. And as they load the questions, I think I can start. And I'm a neuropathologist, so probably I see the diseases in a different way than clinicians. So I will have to disagree with you, and I will bring my arguments, and I think we will have a very good debate. And I will start telling you, I know what my next slide is, about a very interesting patient I saw some years ago. This is a woman, she died at age 71, and in her early 60s, she who was a homemaker and used to be really around her family. She liked very much gardening. She had a kind of very strong husband with strong personality. And according to her family, she barely did activities outside the family home. She liked to garden a lot. And it came to a point that she really lost the interest for gardening. She became really apathetic regarding that. And she started to do something very interesting. She would go out in the morning, take a bus, cross the city. This was in São Paulo, a very large city. And she would spend the day boarding buses and talking to people. So what she liked to do is to talk to people she didn't know. She became a little bit disinhibited. She started to offer comments about her family that she wouldn't do before. And also at the same time, she started to hoard magazines. She liked gossip magazine, but she would read sometimes in the hairdresser and forget about it. And she started to collect it, and she really got upset when people got rid of her magazines. And some years later, she developed motor neuron symptoms, and she got also a diagnosis of ALS. Let's see if my slides will come up. Probably yes. But pretty much this lady, she met criteria for behavioral variant FTD, according to the criteria from 2011. And also because she had the motor neuron symptoms, she got a clinical working diagnosis of FTD plus motor neuron disease. And she came to die, and I got the brain. And I will show you the brain in a minute. And what we saw on her was TDP-43 inclusions, type B, but I would really like to show the slides when it comes. Oh, great. So here we are. Oh, yeah, and I should talk about my disclosures, too. So I have a grant from Avid Radiopharmaceutics, but it has nothing to do with this presentation so far. So this is the patient I just talked about. I think we don't have to repeat. She met criteria for behavioral variant FTD. And this was the results of her neuropathic exam. And so pretty much the area that we really found most degeneration was the dorsolateral frontal cortex, as expected. And here we have this. This is a slide of the middle frontal gyrus, and we have TDP inclusion. So this is not the phospho-TDP. TDP is commonly found in the nucleus of the cells. And then when we have a disease, the nucleus is blue because it's the counterstaining, so it's free of TDP, and the TDP is found in the cytoplasm. And this is a pattern that we call type B. We have 4 types of TDP deposition in frontotemporal dementia. And in addition to this, in the spinal cord, she had also TDP inclusions. This is a very typical scan-like inclusion we usually see in ALS. and she had degeneration of the lateral horn here of the corticospinal tract. Because probably her ALS or motor neuron symptoms did not develop for so long, the frontal part was still kind of preserved. The most interesting of this patient was that she came to us. Well, cannot. Yeah. I'm sorry, I think it's not working. Okay, so here we go. Very good. So this patient came to us actually because of her daughter. So her daughter came to our clinics because she was in her late 40s, early 50s, and she was already starting to develop symptoms that were very similar to her mother. So she stayed about it. Now she's much more developed, and she has a diagnosis of FTD-MND also. And then she talked to us about her mother. So her mother also came to the clinic. She was already in the late stages. But the most interesting is that this mother had a younger brother who had a diagnosis of behavioral variant FTD. It was a pure behavioral variant FTD without motor neuron symptoms at that point, and even today never developed this. And this gentleman had a son who was more or less the same age of our patient, who had pure ALS, and it was already in a wheelchair at that time. And they reported that their father, I mean, the grandfather of our patient, had a diagnosis of Parkinson's disease and a clinic of Parkinson's disease for what they were reporting, and, but never came to autopsy. So it was very puzzling. And this was clearly an autosomic dominant pattern. And we didn't know very much what to do about it until the findings of the C9orf72 mutations was reported in 2011. And actually, this is what this family has. So for those who are not familiar with the C9 mutation, it was reported in the literature in 2011. And it's a very interesting kind of disease because it causes hexanucleotide, so 6 here, expansion in a no-coding region of the C9 of the chromosome 9. And we knew already, I mean, in the field of frontotemporal dementia, that there was familial cases with changes probably in chromosome 9, but it took some time to realize where, especially probably because it was in a no-coding region. So what happens is an expansion disease, like in Huntington disease, but instead of 3 nucleotides, we have 6 nucleotides. It's a little bit difficult to quantify the number of expansions. Now we are a little bit better in doing that. And in all these patients, we have TDP-43 proteinopathy, like in the patient I showed you 2 slides ago, and also some sort of dipeptide inclusions. They are the results of how these expansions are translated. But we know now that despite the fact that we have these dipeptide inclusions, the clinical correlations has to do much more with the areas we find TDP-43 proteinopathy. And from several reports, including from us from UCSF, we know that C9 mutation is the most common cause of familial FTD, and also FTD ALS, and also ALS. So people in the same family, they can present with all these different spectrums, and in some cases even resemble Parkinson's disease, or can manifest with psychiatric symptoms years before the neurological symptoms. And we published about it, and other groups did the same kind of observations. And the C9orf72 mutation just came to consolidate some observations that were done before, that ALS and frontotemporal lobar degeneration or frontotemporal dementia are 2 phases of the same disease, and most of them related to TDP-43 proteinopathy. And these observations, most of them came after TDP-43 was associated with frontal lobar degeneration without tau inclusions in 2006. So maybe you will remember that before 2006, we will classify frontotemporal lobar degeneration as tau positive or as ubiquitin positive but tau negative, but we didn't know which protein was related to this. And then in 2006, by this work of Manuela Neumann in Virginia Lee and John Trojanowski lab, it became clear it was TDP43. TDP43, the gene is called TARPB, is on chromosome 1. There are several mutations described in this gene that it's related to frontotemporal dementia, although they are very rare. Most of them express as ALS of ALS FTD. And last year we published one family with a mutation over here that only have behavioral variant FTD and no ALS. So from the studies that have been looking at ALS and FTLD together, as a summary, they conclude that ALS is, of course, the most common form of motor neuron disease, and then 50% of the ALS will have clinical frontotemporal dementia meeting the research criteria, but a much higher number, 50%, will develop these executive symptoms that maybe if they would survive for a longer time, they would meet criteria for frontotemporal dementia. On the other hand, also 15% of patients that will manifest symptoms as frontotemporal dementia initially will develop ALS features. And I have to tell you that as a pathologist, we pretty much find inclusions in the spinal cord in almost everybody that come with a diagnosis of frontotemporal dementia. So we feel that they have to have the degeneration of the corticospinal cords to have symptoms of motor neuron disease, and we don't find in all patients, but certainly we find inclusions in almost all patients. And of course, when this pathology co-occur, 95% will be TDP proteinopathy, and in 5 of 10% in both cases, it's a familial disorder, and for sure the C9 mutation is the most common mutation in these two different clinical expressions of, I would say, similar pathology. This is a breakdown of the cases we have at UCSF Brain Bank. And as you see, most of the cases with clinical ALS, they will have FTD pathology. Very few cases has a FUS pathology as described by other people. The same is true for FTD, MLD. And it's true, when the patient doesn't have motor neuron disease, so then we have this rainbow here. It can be everything. So probably, as Dr. Bullock was explaining before, we are still optimizing and improving our clinical and also neuropathological criteria for diseases, and probably it will change very soon. So with all this, I would like to really defend that ALS and FTD are a spectrum of the same entity. But I'm not finishing here, and I would like to offer something else. So how can you explain or reconcile the fact that TDP 43 proteinopathy can either express as pure behavioral variant FTD or pure ALS or a mixture of both? So we have some lessons that we are learning from these families with C9 or 72 expansions. This is one paper. It's a multi-institutional and even several continents paper. So it's related to some genes that might influence the clinical expression in patients with C9 mutation. So one of the earliest ones to be reported was this TMEM106B. So for this work, over 300 controls were included, and over 260 patients in this spectrum of FTD, ALS were included. I think we contributed to about 10% of these cases. And this is very interesting. So this is the distribution of different genotypes of this gene in control. So as you can see, most of the people will have this GC. It will be in this GC group. And then the second place will be the CC, and the third place will be the GG. And when you look at patients with pure motor neuron disease, you will see that the distribution is very similar to what we see in controls. But when we look at patients with frontotemporal dementia, again, all of them have the C9 or 72 mutation. We see that these patients, they are enriched in the CG group, and they have much less contributions to the GG group. So the conclusion of this paper, and there are some other papers reproducing this data, is that if you don't have, if you are not in the GG group and you have the C9 mutation, you have a higher risk to also manifest frontotemporal dementia on the top of motor neuron disease. And this is not the only gene that seems to be related to modifications in clinical phenotype. This is another paper. It's also, they use the same patients, it's from the same group, looking at this actacin-2 and repetitions of actacin-2. So as you can see, in these over 300 control cases, no one has intermediate number of repetitions of this actacin-2. But when you look at patients that have frontotemporal dementia, then you have some numbers here, but not in the patients with, this you see more numbers in the motor neuron disease, and in the patients with pure frontotemporal dementia also, no one have this intermediate number of expansions. So the conclusion here was different, that if you have intermediate number of expansions as opposed to normal, you have a higher risk of expressing motor neuron disease if you are C9 or 72 mutations. And with this, I will finish my presentation. Thank you very much.